In this video, I'm going to decode multiple sclerosis. What is it? What causes it? What are the symptoms? How do we fight back? If you're looking for an easy to understand MS 101 video, don't turn away, because that starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. Today, I'm going to be decoding MS, helping you understand what it is, what causes it, how does it present, and most importantly, how do we fight back? In order to understand MS, we first have to consider the immune system. This is the part of our body that fights off foreign invaders. It's made up of little white blood cells that are born inside of our bone marrow and then are released into our bloodstream. And when the white blood cells are born, they don't know what they want to do yet when they grow up. I joke they're kind of like college freshmen, and they go to school at T-Cell University up in the thymus. Now, T-Cell University is a very unusual school. It's free to get in, and there's only one class. Can you differentiate self versus non-self? If I show you one of your own cells, do you recognize it as part of you? If I show you a foreign invader, a virus, a bacteria, a parasite of some sort, can you identify that as a foreign invader? And if you graduate successfully from T-Cell University, there's only one profession: soldier. Literally, you're given weapons and you're sent out into the human body to tool around looking for bad guys. And when you come across a cell that's part of you, you say, "Hey, it's nice to see me." And when you see a foreign invader, you stop what you're doing, you take a picture of the invader to remember it for the life of that human being, and then you call all your friends over and you stomp it to death. You share the picture with all the other immune cells, and so from that point forward, if your immune system sees that virus or that foreign invader, that bacteria again, it pounces on it. It maintains an arsenal against it. Now let's go back to T-Cell University. What happens if you fail the class? What happens if you can't differentiate self from non-self?
They take you out back and they shoot you in the back of the head.
Literally, they wipe out and murder all the immune cells that aren't able to differentiate. Every once in a while, however, the immune system makes an error in judgment, and one of the immune cells fails the class. It can't differentiate self from non-self, and yet it still graduates. And it goes out into the human body, a soldier with weapons, just like all of its friends, and it tools around the human body. But it sees part of us, it sees part of you, but thinks it's a foreign invader and attacks it as such, takes a picture, shares with its friends, and for the remainder of your life, when your immune system sees that part of you, it thinks it's looking at a foreign invader. This is really the underpinnings of the concept of autoimmunity, when your immune system attacks part of you, thinking it's attacking a virus or a bacteria. Now, there are many autoimmune conditions that you're probably already familiar with. For example, if the immune system attacks the pancreas, we call that diabetes. If the immune system attacks the joints of the body, we call that rheumatoid arthritis. Multiple sclerosis is when the immune system inappropriately attacks the supercomputer that runs the body, the brain, and the superhighway, the spinal cord that takes all that information from the brain down to the body and back up. The immune system, when it misidentifies part of our brain and spinal cord as a foreign invader and attacks it, strips off the myelin, the coating on the axons, and breaks the axons, causing brain damage and spinal cord damage, resulting in cognitive and physical neurological disability. Let's take a slightly closer look. The immune system, it's a network of cells. There are regulatory cells and inflammatory cells, and the human needs both, and they have to be in balance. Unfortunately, in the setting of multiple sclerosis, there's an imbalance where there is a paucity of the regulatory cells and there's an overabundance of the inflammatory cells. It's kind of like a city where there aren't very many cops and there's a bunch of robbers. And keeping this pro-inflammatory balance in mind in the background, let's take a look at what I call the lesion-centric view of MS. Sort of a simplified version of the pathology of what's going on. So you have different kinds of white blood cells, different kinds of immune cells. And for the sake of this discussion, we're going to talk about B cells and T cells. Now, the T cell mislearns that part of you is a foreign invader. And in specific, in the setting of MS, it's learning that part of the brain and spinal cord, the coating on the outside of the nerves, the myelin, is a foreign invader. So when it sees myelin, it thinks it's actually looking at a bad guy. And it learns that in the bloodstream. And then it can cross the blood-brain barrier into the central compartment, where it can gain access to the brain and spinal cord, where it sees myelin again, and it thinks it's looking at a bad guy. It requires to be co-stimulated or fired up by the B cells. And when you have a naughty autoreactive T cell that's been stimulated by a naughty autoreactive B cell and it's seeing its target, myelin in the brain, it results in a series of steps that lead to inflammation and causing damage, bringing in army cells to attack that part of your brain, stripping off the myelin and cracking the axons and causing brain damage. Before we move on, I wanted to clarify a few terms. You'll hear me talk about the CNS, or the central nervous system. The central nervous system refers to the brain, the supercomputer that runs the body, the spinal cord, the superhighway that takes all the information from the brain up and down, and the optic nerves, the nerves that run the eyeballs. That's called the central nervous system. MS can attack everything I just listed. The next term I'd like to share with you is neuron. A neuron is the cell in the brain or spinal cord that sends messages from one area to the next. So when you think about the nerve that runs your eye, the optic nerve, it's made up of millions of neurons. An axon is the long part of the neuron that sends electrical messages. When you send an electrical signal down the axon, think of sending an electrical signal down a wire. Coating on the outside of the nerves, the myelin, and that myelin on the outside insulates it and helps you send the signal quickly. So all of the axons in the brain and spinal cord and optic nerves use oligodendrocytes to cover them in myelin. You'll hear me use the term demyelination. So D means nuh-uh, and myelination means covered in myelin. So demyelination means we've stripped the myelin off the nerve. These axons can become demyelinated as a result of multiple sclerosis attacks. If you remove the myelin, the neuron can no longer appropriately send an electrical message. It kind of dies along the way. And if the message can't get there, then that neurological function doesn't work. For example, if that happens in the nerve that runs the eye, you're not going to see. Also, unfortunately, the axons can become transected. Think of cutting the wire, which breaks it and causes irreparable brain damage that we see in the setting of MS. I want to get into some more clinical topics. And I'd like to share with you some risk factors which would predispose some people to be more likely to develop MS as compared to others. The average age of onset is 30. The disease occurs much more commonly in people that trace their ancestry back to Western or Northern Europe, and so folks that are typically Caucasian in the United States. And women present with MS almost 3 times more commonly than men. What are some other risk factors to develop multiple sclerosis? Having a first-degree family member with MS increases your individual risk. Having a childhood history of EBV infection or mononucleosis. Living farther away from the equator, where you're less likely to maintain high basal levels of vitamin D, seems to increase your risk. Exposure to tobacco smoke increases an individual's risk, and childhood obesity is also an independent risk factor to develop MS. Now, just because an individual has some of these risk factors doesn't mean they're going to develop MS. I have a video on the channel, and I'll leave a link down in the description below, where I talk a little bit more about the steps that we think lead to causing MS. And so if you'd like to hear a bit more about that, please check that video out. The most common form of multiple sclerosis is relapsing MS. And I'd like to define a relapse. So a relapse, flare, an exacerbation, an attack, it's when you have a new neurological deficit that's typically focal. So in other words, can't see out of one eye, face burning on this side, clumsy hand, weak leg. Focal neurological deficits. And they generally come on in what we call a subacute fashion. It's not instant like you might see in a stroke, and it's not something that comes on over months and months like you might see in a cancer. The symptoms come on over hours to days, as commonly seen in the setting of inflammation. Think about if you got socked in your eye and your eye swells up. It swells up to the maximal point over the subsequent hours to days. And that's because of inflammation, just like the inflammation we see in MS inside the brain and spinal cord. An attack typically will last weeks to months and then slowly resolve. It may resolve all the way, or it may resolve partially. A few qualifiers when considering an attack. A classic attack occurs in the absence of a fever, preceded by a month of neurological stability, and we look for objective findings on neurological exam. If you have a fever, we may be dealing with a pseudo-attack. This is where, in the setting of increased core body temperature, old areas of damage short circuit and your old neurological symptoms kind of come back out to revisit you. And then when the fever goes away, those symptoms die back down. Please keep in mind that the intensity of an attack, the severity, the duration it lasts, and the amount of recovery is variable, and it can be variable from one attack to the next. Also, the response to steroids is variable from one attack to the next. If you ask about how often does someone have an attack, we have to talk about it in the setting of populations because each person's different. When we look at modern day clinical trials, we would estimate that the attack rate when you're not on therapy is 0.3, meaning one attack every 3 years statistically. I share that with you just as a generalized gestalt. Common attack presentations include optic neuritis, transverse myelitis, and brainstem syndromes. I'll also throw a link right here and down in the description below to a video I did on uncommon MS attacks, in case you're interested in hearing about some unusual and rare MS attacks that I've seen in clinical practice. Another very important concept to understand in MS, separate from attacks, is that of neurological progression. Neurological progression is where a human being develops worsening on their neurological examination independent from an attack. And so someone might have developed difficulty with walking, which is getting slowly worse over a period of years, but they haven't had an attack the way that I described. And this is the concept of progression. Now, I have several videos on my channel dedicated to better understanding progression, and I'll throw a link to a playlist on progression right here and include links in the description down below. Keeping in mind relapses and keeping in mind progression, I now want to turn our attention to chronic neurological symptoms. People with multiple sclerosis can accrue chronic neurological symptoms from one of two ways. One is they have incomplete recovery from one of their attacks. So imagine that they have an attack of hand numbness and it only gets better 50%. Now they're left with somewhat of a numb hand. This is a chronic symptom. And two, neurological progression over decades can result in chronic neurological symptoms. And I'm going to run through a list of symptoms: pathologic fatigue, cognitive impairment, which I refer to as cog fog, mood problems, specifically depression and anxiety, temperature sensitivity, both with difficulties when you're overheated and when you're too cold, visual difficulties, including double vision and vision loss, problems with speaking, like slurring your speech, problems with swallowing, difficulties with walking, difficulties with balance and coordination, weakness of your limbs, difficulties with the down theres, bowel function, bladder function, and sexual function, spasticity, which manifests as limbs that are hard to bend, muscle cramps like a Charlie horse, or spasms and bouncing limbs, and a variety of pain syndromes. We can also see a litany of invisible neurological symptoms in MS. These can include things like cognitive impairment, pathologic fatigue, and depression. When we think about MS clinically, we typically talk about one of two phenotypes. The word phenotype is a doctor word for the outward description. So we have relapsing forms of MS, and we have progressive forms of MS. A relapsing form of MS is a human being that has MS and they have had at least one relapse. This bucket includes clinically isolated syndrome, so-called relapsing remitting MS, and secondary progressive MS with activity. Progression can occur one of two ways. You can have primary progressive MS, where you started progressing from the get-go and have never had an attack or have them very, very rarely. Or it can come secondarily, someone who initially had relapses only, and typically 10 to 15 years into their disease process, they can start to manifest progression. We call that secondary progressive MS. These terms are not the end-all be-all, and they don't do the disease adequate justice. It's my belief that within my career, we will redefine how we describe MS and start to use actual immunologic and genetic terms. That's going to be a lot better for applying treatment. We're just not there yet scientifically. Arguably, one of the best models to understand MS was developed by a friend of mine, Stephen Krieger, in Mount Sinai. He developed a model of MS called the leaking pool model. I'm not going to launch into a description in this video because quite bluntly it would make it way too long, but I will make sure to include links in the description below. And if you're watching this video and you're not familiar with the leaky pool model of MS, please check out those videos because they're really, really helpful in understanding many important concepts of MS, including things that I'm not going to touch on right now, like functional reserve, clinical threshold, activity. Please check those out. In considering an MS prognosis, which is a doctor word for what should I expect to have happen, people with MS are at risk of accruing neurological disability over time. As they have attacks and new spots show up on their MRI, they're accruing focal neurological brain damage and spinal cord damage. And over years, this can cause increasing difficulties in their ability to think clearly and to function within their physical body. Now, in 2019, we're unable to cure multiple sclerosis, but with the early application of highly effective medicines, we are massively slowing it down. I am of the firm belief that the earliest application of the most effective medicine you're comfortable with is one of the keys to success in allowing someone with MS to live a normal life expectancy with a normal or near normal life quality. How do you diagnose multiple sclerosis? Very quickly, there are 5 elements to an MS diagnosis to try to sort out if a human has MS or not. The first one is a clinical history, where we're eliciting a story consistent with MS attacks or a slow insidious progression. The second element is finding objective findings on neurological examination that essentially support the story. So in other words, we have a story that sounds like an optic neuritis, and sure as heck, when I look in their eye, I can see the results of an optic neuritis, the damage that's been done. The third thing we look for is MRI findings that are classic for MS. The fourth thing is abnormalities on spinal fluid. And the fifth element is to ensure that we've ruled out other things that can mimic MS. When a doctor says differential diagnosis, that's a list we make of other things that can mimic the condition we're considering. And so whenever we're confirming a diagnosis, we have to consider the differential diagnosis. Now, the differential diagnosis for multiple sclerosis is enormous. And just in brief, I want to summarize a couple categories. The first is infections. There are infections that can cause neurological deficits and mimic MS. And so very likely your neurologist, as part of the diagnostic workup, will be checking for some of these infections. The second thing we must consider are other autoimmune conditions. There are other autoimmune conditions that can mimic multiple sclerosis or create symptoms that can confuse us. This also includes some cousins of multiple sclerosis, such as neuromyelitis optica spectrum disorder, or NMO, and a newly described condition, anti-MOG. And so your doctor may be ordering a series of laboratories to be looking for these other entities, these other autoimmune conditions that can mimic MS. A third bucket are structural problems that can cause neurological deficits. For example, having a herniated disc in your neck can cause spinal cord problems, which can mimic spinal cord problems seen in the setting of MS. And the last category would be metabolic conditions. So, for example, an abnormal thyroid or a B12 deficiency can have symptomatology that mimics that of MS. I now turn my attention clinically to spheres of management. In other words, how are we going to beat this disease? And there's really 3 spheres of management. The first of the 3 is treating an acute attack. So if you're not having an attack, we're not doing this part. But if you have a new neurological deficit lasting longer than a day or 2, having occurred in the absence of a fever, and with findings on neurological examination, and we're concerned that you're having an attack, we treat it. And I have videos on how do you treat attacks, but in brief, you want to make sure that they don't have an infection. We screen, for example, for urinary tract infections. And once we feel confident in that, we typically give high-dose corticosteroids, very high doses of steroids, to quell the inflammation in the brain and spinal cord or in the optic nerve to hasten neurological recovery. There are other ways to treat attacks, but that's by far the most common. The second sphere of treatment is that of managing chronic symptoms. So managing symptoms doesn't slow down MS, it doesn't speed up MS, and it doesn't treat attacks, but it massively improves the quality of life. It's all about identifying which symptoms bother you and impair your quality of life so that we can then tackle them and make them better. A favorite example of mine is that of erectile function. Some men with MS can develop difficulties with erectile function. If that bothers them, we give them a symptomatic therapy, like a little blue after dinner mint, Viagra, which can improve Friday night. Now, if a gentleman with MS isn't bothered by erectile dysfunction, we don't treat it because it's not going to slow down the disease. On a case-by-case basis, we want to tackle symptoms that bother individuals with MS to improve the qualities of their life. Third category or sphere is the most important, and this is disease modification. And this is where I bring in my concept of being 4 for 4 in your fight against MS. Once again, I'll leave links to videos I've done on the concept of being 4 for 4 down in the description below. In brief, there are 4 things that I'm aware of that can slow down multiple sclerosis. The first one is to not smoke cigarettes, because smoking increases the risk to develop MS, but it also speeds up MS if you have it. And wonderfully, stopping smoking slows it back down. Number 2 is to exercise as part of your lifestyle. I have an entire playlist on the benefits of exercise in MS, and so if you haven't seen that, you might want to check that one out. The third really has to do with diet. And for this video, I'll focus on supplementing low levels of vitamin D. It appears that low levels of vitamin D increase the risk to develop MS, and if you have MS, low levels of vitamin D drive the disease faster, so we oftentimes will supplement those low levels. And the fourth, and one of the most important, is to get on MS medicine and make sure it's working. Once again, I want you to be 4 for 4 in your fight against MS. Let's discuss for a moment goals of treatment, like what we're trying to accomplish. And it's my opinion that we start by setting life goals. I literally want you to verbalize what your goals are in 10, 20 years. I want to walk my daughter down the aisle on her wedding night. I want to finish my master's program. I want to climb Machu Picchu. You got to lay it out there. And the reason is MS is a disease measured by decades. And I want us to be clear in our minds about what our long-term goals are, so we can bend MS to our will and try to accomplish those goals. It also is a touchstone for why we're putting up with all the therapies and treatments. It's because we're trying to accomplish those life goals. Now, as far as the goals of MS disease-modifying therapies go, I'm of the opinion that we're shooting for the concept of NEDA 4, no evidence of disease activity. And this includes ideally having no attacks, no new spots on MRI, no worsening on neurological testing or exams, and normal rates of brain volume loss. I'm saying that's the goal, that's what we're shooting for. In brief, I want you to consider it as a target to shoot towards. If you have that target, you now know if you're hitting it or not. And if you're not hitting it, it allows you to critically analyze, do we need to be doing something else? It's my opinion that we can accomplish NEDA for the best by applying the most effective medicine that you're comfortable with as early as possible, constantly reevaluating, is it working? Are we having attacks? Are we failing the litmus test of life by withdrawing from activities? Are we having new deficits on neurological examination or testing? Are we having new or enlarged spots on MRI? If we're having any of those things, we're not achieving NEDA, and we may need to revamp our plan. We may need to change our therapies or our strategies, or consider different medicines. My name's Boster, and I want to thank you for learning about MS with me. If you want to continue to up your game, click on this video right here. YouTube thinks that you would absolutely adore this video right there. And if you haven't yet subscribed to my channel, please consider doing so just by clicking that circle right there. Until my next video or my next live stream, take care.